we have come a long way in the past 25 years relative to chemo and all these new agents that we've heard about in this meeting. I'm going to talk about another one, which is a radiopharmaceutical. And I kind of mentioned this in my opening remarks, particularly about Arthur Porter and the reports that he gave at this meeting on strontium-89. We've had samarium talks. We've talked about samarium early studies that were done at MD Anderson over the years. Chris Logothetis presented that. So my job here today is to talk about radiopharmaceuticals, where we have been and where we are. Neil Shore just did an outstanding job of presenting the breakfast symposia on radium-223, which I'll talk about in detail. So I'll start out with my key objectives here are to review the last 25 years and how we've integrated radiopharmaceuticals into our practice, talk about therapeutic efficacy and safety, differentiate the different particles, particularly the alpha and beta emitting radioisotopes, discuss the future of where they're going to be in the next 15 years. Let's delve into this. More than 90% of men with symptomatic metastatic castrate-resistant prostate cancer have radiologic evidence of bone metastases. A couple of years ago at this meeting, we got together a group of experts, and it was called the RADAR Group, and it was radiologic assessment of distant disease. And we came up with guidelines on when to do scanning. It was very interesting. In a number of studies that were done, where men were thought not to have metastases. One of those was the IMAGINE study that we did with Janssen with abiraterone in the pre-metastatic, pre-chemo space. About 35 to 40% of men who we thought did not have metastases did have metastases. Identifying metastases is sort of a seminal event, and we've improved on that. We had some discussion earlier about using sodium fluoride PET scans and other things to detect metastases. The issue is all our studies are based on technetium scans and what we do today. So we may be introducing actually something good, but it may also be a very significant lead time bias that we're introducing if we start using all these other scans to detect metastases and so forth. But I think we have to, half of the people that have METs in the castrate-resistant space are men that have PSAs of less than 10. So we have to have this sort of looking out for this events to occur, and they do occur quite frequently. Now, we're going to talk a little bit about METs and the fact that we know that the 5-year relative survival rates for prostate cancer, local, regional, even lymph nodes, is nearly 100%. However, once you have disease that enters into the bone, it's a game changer. And at that point, only a quarter of the people will survive 5 years. And we think that's improving a lot. But these are the old data. We know that there are all sorts of variations and consequences of bone mets. We see people that have super scans that have no symptoms. We have people that have one lesion that are in dire pain with symptoms. But we know that bone disease can result in severe pain. It's significant that you got a double whammy that occurs here with prostate cancer. You have androgen deprivation therapy, which is inducing treatment-induced bone loss by low T. But we also have pathologic fractures that occur because of where the disease is and because of ADT, androgen deprivation therapy. We also know that one of the most serious and dreaded events in prostate cancer is spinal cord compression from involvement directly or from fractures, mostly paraplegia. It's an emergency. We still see those. I saw a lot of them when I was a resident, but they're still around. One of the drugs that I'll talk about, radium-223, in the ALSYMPCA trial actually reduced the rate of this event happening. And so also you can have your marrow packed with prostate cancer, have a effect on your white blood cells and so forth. So that is something that is around. The Curies, Madame Curie in the late 1800s, and then in 1903, when she presented her doctoral thesis, also got a Nobel Prize for describing radium. Radium was felt to be one of the significant events, and it was maybe a cure for cancer back then. Well, we all know that that was not the case, that a lot has changed in the way of radiation therapy and radiation oncology, but in fact, it was a step forward. And those of you that remember this from chemistry will remember the periodic table. And if a lot of these drugs that we're talking about follow calcium, so calcium is turned over in bone, and what we see is integration of that into bone. And so these drugs like strontium mimic calcium, barium and radium. Samarium doesn't, but if you hook it up to something that acts like calcium, it gets into the bone. So all these things that we're talking about here, these radiopharmaceuticals mimic calcium. So strontium-89 is, as you saw in that periodic table, is a calcium homologue, so it tracks calcium deposition and turnover, which is occurring in men who have bone mets, and in women with breast cancer, men and women with other cancers. Samarium is hooked up with EDTMP, so it mimics calcium, and so that way it tracks the bone. Phosphorus 32, I'm not going to mention much about that. That's what I had when we were a resident, is an effective but extremely toxic radiopharmaceutical. Now, strontium, I mentioned this in my opening talk, was developed in the late 80s and 90s, and the pivotal trial was done by Arthur Porter. It was called the Trans-Canada Trial, and it took a small number of men, 126, and randomized them to strontium-89 plus local field radiation versus a placebo and local field radiation. The primary endpoint was not survival, but it was pain. And in this Trans-Canada study, reported by Porter in 1993, what was seen was back in this time, and this is really in the pre-PSA era too, that it was effective in reducing bone pain with a p-value in that small number of patients of 0.002. Now, the problem with the radiopharmaceuticals back then, and still, is the hematological toxicity, which can be significant. Strontium-89 compared to placebo, there was 10% grade 4 platelet toxicity versus just under 2% with the placebo. Same thing with white blood cells. Now, samarium had a little bit less in the studies that were done back in the 90s also. So how do these things work? The alpha-emitting drugs, and then we'll talk about the beta-emitting drugs, are that they track to the tumor and they release their energy. They have different actions. If we look at sort of a cartoon of the size of a beta particle, it might be the size of a BB, where the size of a alpha particle is much larger and is such that you can imagine that the penetration of the smaller particles through the bone into the bone marrow is more significant with a beta particle than it is with an alpha particle. And so Neil Shore used this example of throwing a beach ball against the screen versus a BB. You have to be pretty strong to get a beach ball to do anything. So I think it was like throwing a basketball hard against the screen. It's going to dent the screen, but it's not going to go through it. If you shoot a BB in there, it's going to go through it. So they're a little bit different in their power behind them. One packs more punch, but it doesn't have a deep punch. And so if you look at the relative particle mass here of alpha versus beta particles, you can see that 7,300 versus 1. And if you look at the energy that is released, it's more significant with a alpha particle than it is with the beta particle. And if you look at the penetration that occurs, the difference between alpha and beta particles, a significant difference in how deeply it penetrates. So again, the disadvantage of the beta particles have to do with the fact that they're deeper penetrating and can cause more hematological and bone marrow side effects. Now, the second thing is that what we're trying to do is rid the patient of the tumor and have more bone healing and things occur. So if we go ahead and sort of summarize this in this table with all the things that are out there from going back and looking at phosphorus, samarium, strontium, what we see here is the level of energy that is present with radium is on the relative scale of 27 to 1.46 for strontium and 0.81 for samarium and 1.71 for a relatively toxic drug, and that is phosphorus. Again, so this is more of a short-range, lethal double-stranded DNA break that occurs. So this is new in the last 25 years. We've been talking at this meeting about the strontium and samarium and trials with that, and that sort of lost its shine for a while, and then along came sort of the rediscovery of radium and integration into trials. So let's talk about those trials. We have the trial that was done, first of all, was a phase 2 trial, which showed that radium-223 compared to a placebo worked. That's the right way to do trials, phase 1, phase 2. The next one is a phase 3 trial. And the phase 3 trial is called the ALSYMPCA trial, which means ALpharadin in symptomatic prostate cancer. I like the term ALpharadin. The term that the name that was assigned by the FDA was Xofigo. So I use radium-223 a lot when I talk about it. This is a trial that was designed to look at normal care, but using radium-223 versus the placebo, with the endpoint being survival. Other things that were looked at, we'll talk about in a minute. But I was actually involved in the design of this trial, and I was not in favor of it. I thought that there was not going to be any chance that this drug would have an effect on survival. But anyway, so it was almost over 900 patients. They had to have bone mets, no visceral mets. You could have lymph node disease, small lymph node disease, and you could have docetaxel. Most people were supposed to have it, or unfit for docetaxel, but most of the time people didn't want it, or it wasn't available where a lot of the sites were in Europe where this was done. And then they were stratified based on alkaline phosphatase, things like that. So the endpoints were overall survival rate. Then other things were looked at, including alkaline phos progression, PSA progression, quality of life. It was about 3 years ago, I think. I remember maybe 4 years ago, I got a phone call at Christmas time from then the medical director of the company, and he said, and Bayer was sort of co-marketing this, and he said, they just stopped the study, the Data Safety and Monitoring Committee, and I said, oh my God, this means that this drug is toxic, and he said, no, there was a survival benefit. We were all shocked. It was presented at this meeting for the first time to see something like that. If you look at this is a good study. It's well balanced. You can see the median age is 71 in both arms, alkaline phosphatase elevation in half the patients. This is important. Everybody thinks that this drug sort of should be, not everybody, but a lot of people sort of focus on men circling the drain with the disease, so to speak, post-docetaxel. If you can see here, 40-some% of the men had not had prior docetaxel, and almost half of them were not taking opiates. They were taking some pain medication. So this is not just for people that are far advanced with the disease. And you can see a lot of them had metastases, extensive metastases. There were two results that had been reported. One was a planned interim analysis. That was the one that closed the study in December. And that one showed a significant survival benefit. Now, by the time you get the word out and stop the other people on the drug, the people on placebo, whatever, there was some time. So during that time, they gathered more information. That was called an exploratory updated analysis. And that one actually gave one of the more significant differences. Both of them had a significant difference in survival rate of 11.3 versus 14.9 months. And here's the updated analysis, as you can see here, a significant difference in overall survival rate, which was the endpoint of the study. And then it was looked at prior docetaxel and no prior docetaxel. What you can expect is you have a better outcome in people that had no prior docetaxel, but it was still there in both groups. And then there was something called SREs, skeletal-related events, and then symptomatic skeletal events. Both were improved with this drug. And the safety profile was there. Both the adverse events were actually the same pretty much in the placebo as they were in the radium-223. As a matter of fact, some of the hematological toxicity was more in placebo than it was with radium-223. So the other issue was, can you give the drug after men have had chemotherapy, after they've had radium, worrying about the bone marrow? And in fact, what was seen is they did that, and there was not a significant increase in toxicity. So radium-223, how is it given? You don't give it in your office. You don't send them to Walgreens to get the script. It's usually done, it's done either through a radiation oncologist, which is about half of how it's used in the United States, or nuclear medicine. We do it through nuclear medicine. We have a treatment plan, and our EPIC order it. They come in, the drug's ordered. They get it for 6 months. They get it once a month, and it's a quick 60-second IV infusion by the radiation oncologist or nuclear medicine folks. You do check CBCs before. We've been checking them and have not seen any issues, but you should be looking at platelets and things like that. So finishing up here, Neil's going to talk about this, but we have all these new drugs now that have a survival benefit, and they're all different, and radium-223 is different. So that's what's happened in the past 25 years. What I think going forward is, what we learned from this trial is that radium-223 is a game changer relative to prolonging survival. It reduced skeletal-related events and symptomatic skeletal events, and it was well tolerated, much more so than we saw with the other things. And now we have all these new studies out there that Dan showed and Neil's going to talk about, and how we sequence this in the future. All these things are moving up further. Dan and I had a meeting earlier in this meeting where we talked about the kitchen sink protocol, where we're going to take newly diagnosed metastatic patients and throw the kitchen sink at them. And that means that they're going to be looking at hormonal therapy, combined androgen blockade. Well, they're going to get chemotherapy early based on the study that Dan showed, the ECOG study. They're going to get some of the 17-hydroxylase inhibitors, abiraterone. They're going to get radium-223 early. They're going to have bone protection. The primary is going to be treated. And I think about how we sequence in drugs like enzalutamide or ARN-509 as we go forward. And so this, I think, is the future. It's going to be, and it's not going to be they're going to get this forever. It's going to be short-term. Every cancer that we cure with chemotherapy, it's not one drug, it's not two drugs, it's 3 or 4. And the treatment is not lifetime. It's usually for a definitive period of time. And so that's where we go for here. So that for the future, it may not be the ultimate question of sequence. It may be a question of overlay. So how these things, it's not, A, B, C, and D. It's how they go forward.